and winners for the best paper will be announced at the inauguration ceremony, which will be at 1 o'clock. Each paper will be judged for the scientific content, that is 10 marks, originality, that is also 10 marks, presentation and clarity, 10 marks, and completing within the time limit. The decision of the scientific committee will be final. I would like to call the judges for the session, and I would like to invite the first presenter, who is Dr. Koduri Suraksha from RIMS, Ahmedabad.
Please go ahead. You need not introduce yourself. You can directly start with your presentation because you have only 3 minutes.
Good morning everyone. Today I am going to present a case report of Cartagener's syndrome, which is a rare condition diagnosed in a young female patient. Introduction. The Cartagener syndrome is a group of ciliary motility disorders called primary ciliary dyskinesias. It is a genetic condition, an autosomal recessive condition. In this, it mainly affects the structure and the function of cilia, which ultimately leads to the defective movement of the cilia and leads to recurrent chest infections, ear, nose or throat symptoms, and also infertility. It includes triad of situs inversus, chronic rhinosinusitis, and bronchiectasis. Case details. A 23-year-old male patient presented with the complaints of dyspnea on exertion since 10 years, increased since 1 week. Cough with expectoration since 10 years, increased since 1 week. Fever on and off since 1 week. Infertility. The past history, the patient gives recurrent history of rhinitis and cough with sputum since 10 years. Vitals, pulse rate is 100 beats per minute, blood pressure is 100 by 70 mmHg, respiratory rate is 35 cycles per minute, saturation is 93% under room air. On clinical examination, in palpation, apical impulse is felt on right fifth intercostal space in the mid-clavicular line, and on auscultation, heart sounds are best audible on right side. And respiratory examination, bilateral inspiratory crackles present in infraaxillary and infrascapular areas. Chest X-ray showing dextrocardia with bilateral ectatic changes in middle and lower zones. ECG shows positive positive deflection in the lead AVR and poor R-wave progression from lead V1 to V6. The USG abdomen and pelvis, it shows liver on the left side, spleen on the right side, and appendix in the left iliac fossa. HRCT, it shows bronchiectatic changes and cardiac apex towards right side. CT abdomen, liver, inferior vena cava on left side, spleen, aorta on right side. CT PNS, it shows pansinusitis. Discussion. Disorders of ciliary motility may be congenital or acquired. Congenital disorders are called as primary ciliary dyskinesias. Nearly 50% of the primary ciliary dyskinesia patients have situs inversus. 38% of the primary ciliary dyskinesia patients carry mutations of the gene dynein genes DNA I1 and DNA H5. This underlying defect leads to the accumulation of secretions and stasis. The severity of the symptoms and the age at which the condition is diagnosed is quite variable. Diagnostic criteria includes abnormal absent tracheobronchial clearance, dextrocardia in the patient or in the sibling, alive sperm cells with impaired or absent motility. In case of females, amenorrhea may be present. This is the image showing the chest X-ray showing dextrocardia, images of the CT abdomen and the CT chest. Conclusion. One should always keep in the mind the possibilities of Cartagener's syndrome in patients whenever the patient is present with a history of recurrent respiratory tract infection, sinusitis or bronchiectasis. Early diagnosis and prophylactic measures help to prevent unnecessary and repeated hospital admissions. Genetic counseling and fertility issues should be addressed if the Cartagener syndrome is diagnosed. Lifestyle modification and education of the patient has also plays a major role in the long-term survival of the patients.
Sir, you may ask your questions now.
Can you just tell what is the cause of bronchiectasis in Cartagener syndrome?
Due to the defective movement of the cilia, so there will be stasis of the secretions, which leads to the obstruction of the dilatation of the bronchi, obstruction and dilatation of the bronchus.
So recurrent infections?
Recurrent infections.
Okay. Any role of FeNO in screening for primary ciliary dyskinesias?
Yes, sir. In primary ciliary dyskinesia, there will be a decreased exhale nitric oxide due to the nasal epitheliary damage will be
Less than how much?
less than 100 nanograms per m.
20.
Less than
Okay. I also invite Dr. Ashish Kendre to please be one of the judges, sir. And there will be a sheet circulating around people who want to participate in the quiz, which I expect that all of you are participating. Kindly note down your names in that sheet.
Thank you. I now invite the next presenter, Dr. Adarsh A. Joy from RIMS Adilabad.
Good morning, everyone. Today I am presenting a case report on pulmonary alveolar proteinosis. It is a disease characterized by abnormal accumulation of surfactant in the alveoli leading to hypoxic respiratory failure, mainly of three types: primary, secondary, and congenital. So primary is mainly caused by the impairment of GM-CSF dependent surfactant clearance by alveolar macrophages, which may be autoimmune or hereditary, constituting around more than 90% of cases. Secondary PAP is something which is secondary to some other pathology, which may be mostly hematological, constituting 70% of cases. Other causes may include infections, autoimmune diseases, and it may be associated with other occupational disorders like silicosis or getting exposed to noxious fumes or gases, and it may present as a systemic manifestation of underlying diseases like HIV. So, and congenital PAP, the third one, is caused by defects in the genes encoding surfactant protein B, C, ABCA, lipid transporter type 2 alveolar epithelial cells, or mutation in the surfactant proteins. So coming to the case detail, a 40-year-old female came to OPD with complaints of shortness of breath on exertion for over 1 year, not associated with wheeze, along with complaints of weight loss and anorexia. Chest X-ray and HRCT was done, and on examination, bilateral breath sounds were reduced and crepitations were present bilaterally. So initially with these complaints, patient had visited a local hospital for which initially investigations were done, and she was empirically started on ATT. But in spite of taking ATT for 6 months, she didn't have any improvement. So she came to a hospital where routine investigations were done, and imaging was done where HRCT was suggestive of crazy paving pattern. Other investigations which we did was PFT, which was showing a restrictive pattern, and bronchoscopy was advised. And those washings revealed milky whitish fluid, which predominantly constitute lymphocytes of 87%, and eosinophils were also present, which was periodic acid positive and diastase resistant, which was suggestive of PAP. And it revealed negative for malignant cells, and but predominantly eosinophils were seen. Bowel CT was done, which came out to be negative. Bowel culture showed pseudomonas. No fungal elements were seen, and the management part, patient was initially made to undergo a right side lavage under general anesthesia, then followed by a time gap of 1 week. She was made to undergo lavage on the left side, and thereafter she was treated conservatively with IV antibiotics and bronchodilators, with which she improved symptomatically and was discharged in a stable state, and regular follow-up was advised, and she came out to be asymptomatic after 2 years. So on the left side, the images, like initially when she came to hospital, the images were done. It's on the left side, and following treatment, the images which were taken is shown on the right side. So conclusion is like bronchoalveolar lavage or the whole lung lavage is the ultimate treatment modality for a patient presenting with pulmonary alveolar proteinosis. Thank you.
Is crazy paving pattern pathognomic of PAP?
No, sir.
So can you give a list of differentials of crazy paving pattern on CT?
So pulmonary edema might be there. Pulmonary edema, then some mycoplasma pneumonia, even acute respiratory distress syndrome.
Okay. Any literature review on spontaneous resolution of PAP in recent times?
No, don't.
No. Okay. Good.
Thank you. I now invite the next presenter, Dr. Lokesh Rande from PDMC Amravati.
Good morning. A 52-year-old female patient resident of Amravati came to OPD with chief complaints of breathlessness, cough with sputum and fever since 7 days. She was apparently all right 7 days back when she developed breathlessness, which was insidious in onset, gradually progressive in nature, progresses from MMRC grade 1 to grade 3, which aggravates on doing activity and relieves on rest. She also developed cough, which was insidious in onset, progressive in nature, not relieved on medication, with no aggravating or relieving factor associated with sputum white in color without hemoptysis. The fever was sudden in onset, high grade, intermittent, and associated with chills, malaise, body ache, and night sweat, which are temporarily relieved on antipyretic medication. There is no history of hypertension, diabetes, tuberculosis, asthma. A patient failed to conceive throughout the life. There is no significant personal and family history. She has a history of repeated medications for cough and cold in the past. There is history of treatment taken for infertility. On general examination, patient has a grade 3 clubbing, while the rest all findings are normal. On inspection, apex impulse seen on right side, which later confirmed on palpation. Rest findings on inspection and palpation are normal. On percussion, we get right heart border found at 2 centimeter lateral to right midclavicular line in the fifth intercostal space, while left border felt 1 centimeter lateral to sternal border. On auscultation, bilateral coarse crepitations heard in inframammary, infraaxillary, and infrascapular areas. Occasional rhonchi heard. Other systemic findings are within normal limit. Based on history and clinical examination, the differential diagnoses are dextrocardia with obstructive airway disease or interstitial lung disease or bronchiectasis. On X-ray chest PA view, we get a right side aortic arch with dextrocardia with bilateral cystic opacities in mid and lower zone. On HRCT thorax, we get multiple cystic bronchiectatic changes with signature appearance and situs inversus. And on X-ray skull, we get absent frontal and maxillary sinuses. On basis of clinical and radiological findings, the diagnosis for this case is a Carter-Jenner syndrome. It is a type of primary ciliary dyskinesia caused by mutation in axonal dynein intermediate chain gene and is autosomal recessive condition. A triad of bronchiectasis, situs inversus, chronic sinusitis, along with chest X-ray, USG thorax, and HRCT thorax findings can diagnose Carter-Jenner syndrome. Failure to conceive even after infertility treatment and a recurrent history of respiratory tract infections and otitis media is usually associated with it. There is no treatment has been shown to found correct ciliary function in patients with Carter-Jenner syndrome. The only options are pulmonary rehabilitation, chest physiotherapy, antibiotics, mucolytics, lung transplant in severe cases, assisted reproductive technology, influenza and pneumococcal vaccines, and avoid smoking and exposure to smoke and other pollutants. Thank you.
Can you enumerate some reasons for a lung transplant, like guidelines?
Guidelines.
This patient.
Severe lung destruction, old occupational lung disease or old tuberculosis.
No, in this patient,
Carter-Jenner.
Yeah.
Patient not maintaining saturation or and requiring long-term oxygen therapy may require lung transplant. Or in severe lung destruction or
That's what, there are certain guidelines, right? Okay, fine.
Okay.
Thank you. I now invite the next speaker, Dr. Akifa Fayaz from RIMS Adilabad.
Good morning, esteemed faculty. Today I'll be presenting a rare case of postpartum pulmonary embolism. Pulmonary embolism is a condition where there's a thrombus that migrates from the systemic circulation into the pulmonary vasculature. This is a critical and potentially life-threatening condition, especially in high-risk groups like pregnancy and postpartum. The risk in pregnancy is 5-fold, and in postpartum it's about 60-fold. Pregnancy remains risk factor with odds ratio of less than 2, while postpartum it is 2 to 9. There are certain physiologic changes in pregnancy that predispose the patient to pulmonary embolism or thromboembolic episodes, like increase in factors 2, 7, 8, 10, and an acquired resistance of protein C resistance and decreased free protein S levels. And there is venous stasis. Now, the case that came to us was a 23-year-old female with recent history of stillbirth. She presented with unilateral leg swelling, fever, and sudden onset dry cough, chest pain, and dyspnea. On examination, the patient was tachypneic, tachycardic, and the oxygen saturation was of 90%. On doing the laboratory investigations, the positive findings were elevated D dimer and ESR, and the platelets were decreased to 1.1 lakhs. When duplex imaging was done for the leg swelling, we found that there was thrombus in the common iliac vein, external iliac vein, superficial femoral and popliteal veins, followed by CTPA. And in CTPA, we found that she had multiple bilateral infarcts. The patient was hemodynamically stable and was hence managed on low molecular weight heparin. No need for thrombolysis or surgical intervention was seen. Further monitoring was done with APTT levels, and the range of 1.5 to 2.5 was suggested. And venous thromboembolism in pregnancy becomes hard for diagnosis because the normal symptoms that we see in pregnancy mask the symptoms for VTE. For example, we see normally that the pregnant female might have leg swelling. She might have dyspnea. And D-dimer levels are also increased. The baseline D-dimer levels are increased in pregnancy. So we have some rules if the patient is pregnant and we don't want to put her under radiation. We use some rules like left rule and yes criteria. And these are the CTPA and CT thorax images from the patient. On X-ray, we see that there is a left lower lobe, left lower zone consolidation with some effusion and infiltrates. And timely diagnosis and initiation of anticoagulation are critical for reducing morbidity and mortality. And for pregnancy and postpartum patients, especially in the first 6 weeks postpartum, the risk is 60-fold, so high index of suspicion should be maintained.
How long would you like to continue the LMWH in pregnancy?
Sir, the minimum duration is supposed to be 6 weeks minimum, but 3 to 6 months is what is suggested, sir.
Would you like to continue it at the time of delivery?
So at the time of delivery, it depends on the procedure we're doing. For example, if it's cesarean we're doing and we've already started her on LMWH, we change it to UFH. That has reversal agents are available, short duration, and it's less thromboembolic, less bleeding episodes and stuff. So we can change it to UFH at that and later start on LMWH.
Ideally, which parameter is used for monitoring LMWH activity?
So APTT. So
any factors?
Factor 10, sir. Factor 10.
10A.
10A, sir. Factor 10A. Thank you, sir.
The most of the times APTT has not shown to corroborate with LMWH monitoring. Most of the times. So that's the reason when you use an LMWH, you don't monitor at all. So you use a therapeutic dose and you see for the response. Because factor 10A you cannot get anywhere to be monitored so easily. The ideal way is to use an LMWH, especially when you're discharging the patient. But in an active critical state, usually we use heparin so that we can monitor the PT. So, but if you want to monitor LMWH, probably APTT is not a good option.
Okay, sir. Thank you, sir.
Thank you. I now invite our next speaker, Dr. Mahalakshmi S. from RIMS Adilabad.
A very good morning to one and all present here. I'm going to be presenting about tuberculosis, which is confined only to the maxillary sinus, a rare manifestation of sinus tuberculosis. Usually, extrapulmonary tuberculosis is most common manifestation is in the cervical lymph nodes. Coming to the sinonasal tuberculosis, it is very rare in presentation mainly due to the architecture of the nasal mucosa, due to its unidirectional mucociliary clearance and the bactericidal properties of the nasal secretions. This primary sinonasal tuberculosis is rarely encountered even in developing countries and endemic countries. It is usually seen secondary to pre-existing focus elsewhere in the body. Hence, high index of suspicion is important for timely diagnosis and proper treatment due to its non-specific clinical presentation and other close differential diagnosis. Here we are presenting a case of primary tuberculosis which is confined to the unilateral maxillary sinus in an immunocompetent female. Ours is a 63-year-old female who presented with no comorbidities, complaints of nasal obstruction, nasal discharge, and gradually increasing swelling over her face on the anterior aspect of the left cheek for the past 3 months. Nasal discharge was mostly mucopurulent and sometimes bloody. She received several courses of antibiotics and other symptomatic treatment without any improvement. On examination, there was a non-tender swelling over the nasolabial area and smooth fleshy growth in the left nasal cavity. Her CT showed irregular soft tissue opacity in the left maxillary sinus, causing partial erosion of the medial wall of the left maxillary sinus. All other system examination was normal. Biopsy from the diagnostic nasal endoscopy showed stratified squamous epithelium with underlying dense inflammatory cell infiltrates and epithelial granuloma with Langerhans giant cell, and AFB stain was also positive. These are the things which help for the diagnosis and which are the criteria to call it as a sinonasal tuberculosis. There are 3 criteria, mainly the non-response to other antibiotics, and the next is surgical specimen with AFB stain positive. Medical literature has only very few cases of primary sinonasal tuberculosis. Our patient received, we ruled out all the other differential diagnoses such as fungal rhinosinusitis, and then we started the patient on antitubercular therapy and proceeded to endoscopic sinal surgery for debulking the lesion. After 4 months, there was no residual mass lesion was seen. Here is the Ziel-Nielsen stain showing acid-fast bacilli, hematoxyl neosin stain showing Langerhans giant cell, and CT paranasal sinuses showing soft tissue opacity. To rule out the primary focus, chest X-ray was normal. Primary sinonasal tuberculosis is more common in females with the mean age being 40 years. Symptoms are very non-specific. It can involve any part of the nasal septum, inferior turbinates, could be ulcerative, proliferative, or infiltrative. Only with a high index of suspicion and ruling out other differential diagnosis, the diagnosis is clinched. The other differential diagnoses are usually the fungal.
Was a CB-NAT sent?
CB-NAT sensor.
So it was
induced sputum and even bronchoalveolar lavage was also done. It was negative, sir.
no from nasal. Any nasal discharge was there? The patient had.
Nasal discharge was there, sir. But
So was it sent?
yes, sir.
So it was negative.
It was negative, sir.
Okay, because AFB is positive. Then
Sir, AFB was positive from the nasal endoscopy. The tissue AFB was actually
on histopath. Okay.
histopath.
Respondent to it.
So what is the prevalence of this tuberculosis?
Sir, it is very less. Almost like medical literature, primary sinonasal tuberculosis in the medical literature, there are only 40-50 cases, documented cases, sir. Secondary sinonasal tuberculosis is a bit common, but primary is very rare.
But it has to be sent sometimes.
So the treatment is standard.
Yes. Yes.
Okay.
Thank you. I now request Dr. Girish Sri Dhara Kumar from RIMS Adilabad.
Good morning, everyone. Today I'm going to be presenting on a rare case of chronic silicosis with MDR TB. Silicosis is a progressive ILD characterized by shortness of breath, cough, fever. It can present in 3 different forms: acute, accelerated, and chronic. It is caused by lung tissue reaction to the inhalation of silica and occurs most commonly as an occupational disease of people working in quarry, manufacturing, and construction. Among clinical complications of silicosis in TB and chronic exposure to silica increases workers' risk of TB infection and aggravates pre-existing pulmonary TB. The present case is a rare presentation of silicosis with MDR-DP. 65-year-old female came with chief complaints of productive cough with 2 months history, low-grade fever with evening rise of temperature since 1 month, progressive dyspnea since 1 month. She worked in a rock crushing silica mining industry since 30 years. Bronchial washings, CBNAT showed MTB positive with RR detected. CCT chest showed patchy areas of consolidation noted in bilateral upper lobes and superior and posterior basal segment of left lower lobe. Bilateral enlarged lymph node and paratracheal highlight regions with axial calcification. PFT showed restrictive pattern. Mainstay for diagnosis of silicotuberculosis are X-rays, protein for AFD, CBNAT, CT chest. Differential diagnosis includes mycobacterial fungal disease, malignancies, rheumatoid nodules, Kaplan syndrome in presence of cold workers pneumoconiosis, sarcoidosis, pulmonary langerhans cell histiocytosis. There is no active treatment specific therapy for chronic silicosis. All patients with radiographic evidence should avoid further exposure to respiratory silica. Corticosteroids and aluminum citrate have been used with varying success, with corticosteroids having limited efficacy in treatment. Short course ETT for PTB and long oral regimen for MDR-TB with silicosis. There is X-ray and CCT of the patient with silicotuberculosis, with X-ray showing hilar lymphadenopathy. A partial explanation for poor response has been attributed to impaired macrophage functioning and poor penetration of drugs into the fibrotic nodules. Prevention through medical surveillance, dust control measures, and comprehensive policy framework, which is recognized by NHRC.
How will two questions? Just first question is, how will you do microbiological monitoring of this patient on treatment? Which is the anti-TB regime you started?
For MDR-TB with silico, we use a longer oral regimen.
Conventional or longer? Okay. So how will you do the microbiological monitoring while on AKT of this patient who was diagnosed on BAL A, this CBNAT?
Second and fourth.
What sample would you like?
BAL.
So will you do periodic BAL?
Periodic BAL, after that sputum.
So on sputum, which test would you like to do?
Microscopy.
AP smear. Okay. Do you know what is the current recommendations or the which is the newer regime in MDR-TB which has come? Okay. So can you just tell me the inclusion criteria of BPAL-M? No. Acha. ठीक है. What is the pathogenesis of TB in silicosis?
Silicosis.
Any specific that silicosis patients are more prone to TB?
Because of impaired macrophage functioning, they have they are more prone to TB infection, mycobacterial infection.
Anything related to iron transport?
Thank you, sir.
Thank you. I now invite Dr. Mit Shah from PDMC Amravati.
Good morning, everyone. My title of today's presentation, a bizarre case of suspected lung abscess. Endobronchial tumors in rare cases present as an empyema and lung abscess, often mimicking a benign infection. Here we present a rare case of squamous cell carcinoma, initially suspected to be a lung abscess, emphasizing the necessity of thorough assessment and follow-up for resolution. A 72-year-old male farmer, 15-pack-year smoker, chronic alcoholic, presented with chief complaints of breathlessness, cough with expectoration, and weight loss with reduced appetite since 1 month and fever since 15 days. He denied hemoptysis, night sweats, chills, rashes, or any prior diagnosis or exposure to tuberculosis. He was vitally stable with a BMI of 18.28. On physical examination, tactile vocal fremitus was reduced in left inframammary, infrascapular, and infraaxillary regions, and on tidal percussion, dull note remained dull. On auscultation, breath sounds were reduced over the above mentioned regions. Chest X-ray was suggestive of a cavity with air fluid level, which was suspected to be a case of lung abscess. Blood investigations revealed anemia with septicemia with acute kidney injury. Broad spectrum antibiotics were initiated. USG thorax was suggestive of left loculated pleural collection, which was non-tappable. Patient was further scheduled for CECT thorax. On CECT, left side loculated dependent pleural collection of 12 by 8 by 8 cm with multiple gas bubbles giving split pleura sign with mediastinal lymphadenopathy. Areas of consolidation with ground glass opacities were noted in superior and basal segment of left lower lobe. Antibiotics was kept up, but as the symptoms were not resolved, patient was posted for bronchoscopy. On bronchoscopy, whitish growth was noted in left lower lobe, which appeared to be a mucus plug or a foreign body. Bronchoalveolar lavage was negative for malignancy. Endobronchial biopsy showed a non-small cell carcinoma, squamous cell carcinoma. This is a unique presentation of squamous cell carcinoma of the lung presenting simultaneously with an ipsilateral empyema as evidenced by diagnostic imaging. Squamous cell carcinoma is very strongly related to cigarette smoking than any other type of non-small cell cancer. It accounts for 20 to 30% of all the lung cancers. When squamous cell carcinoma presents as an empyema, it may cause symptoms such as chest pain, cough, fever, breathlessness. The presence of an empyema can complicate the clinical picture resembling pneumonia. Therefore, when a patient presents with an empyema, one should ensure ruling out or keep ipsilateral malignancy as a differential diagnosis. Thank you.
So this was a case of post-obstructive consolidation due to malignancy, secondary to malignancy.
Yes, sir. On X-ray, we were suspecting a lung abscess, but it turned out to be malignancy.
Okay. So what is the most type of lung carcinoma in smokers?
Adenocarcinoma, sir.
Right. And this one was?
Squamous cell carcinoma.
Okay. IHC was done for this patient?
No, sir. At our center, it is not available.
Okay.
So we
How do you
refer.
proceed with the case?
Sir, for symptomatic relief for the patient, first we'll like to drain the empyema by ICD or by through thoracoscopy, and then later we'll do PET scan for further evaluation, and also MRI brain for brain metastasis.
I just wanted to ask you because you showed the CT scan. The CT scan was not showing any endobronchial obstruction.
No, sir.
In the left main bronchus, nothing.
No, sir. It just gave the split pleura sign, so it was suspected to be empyema. So
I'm not talking about the empyema. I'm talking
No,
about
sir.
the left main bronchus.
No, sir.
So such a large mass, usually you will get picked up in the CT scan, right?
No, sir. It didn't come out.
Is the patient clubbing?
Yes, sir.
Can you name a lung malignancy which does not show clubbing? Any specific pathological type of lung malignancy which does not show clubbing?
Not sure, sir.
Thank you. I now invite Dr. Harshada Ambekar from PDMC Amravati. She's not here?
I'm here.
Oh, she. Okay.
Should I start? Okay. Good morning, everyone. My title for today is an unusual case of chronic cough. Case of a 52-year-old known case of hypertension with diabetes mellitus type 2 presented with chief complaints of dry cough, progressive dyspnea and intermittent fever on and off since 1 to 2 months. Despite broad spectrum antibiotics, corticosteroids and supportive care including NIV at a private hospital, her condition persisted. Systemic examination revealed bilateral fine crepitations in infraaxillary and infrascapular region. Baseline hematological and biochemical investigations were within normal limits. Initial HRCT thorax revealed bilateral interstitial and consolidative changes. Repeat scan revealed patchy consolidation, bilateral moderate pleural effusion, interlobular interstitial thickening in bilateral lung fields consistent with interstitial pneumonia.
Serological workup showed ANA positivity with anti-Jo1 and anti-Rho52 antibodies, suggesting an autoimmune etiology. However, she did not fulfill the criteria for a definitive connective tissue disorder, thus meeting the diagnostic criteria for interstitial pneumonia with autoimmune features. Pleural fluid analysis of the moderate pleural effusion revealed exudative lymphocytic CB9 detected MTB, leading to initiation of antitubercular therapy under DOTS. Treatment, the mainstay of treatment was NIV and inotropic support, broad spectrum antibiotics, and low dose steroids. Patient was symptomatically better, showed clinico-radiological improvement, and was advised home O2 support on discharge. These are images showing the initial X-ray on admission showing bilateral heterogeneous lower zone opacities, the CT scan and ANA blot positive report for anti-Jo1 and Rho52. This is a series of X-rays showing resolution of disease over a period of a month's time. Discussion is on IPF. Interstitial pneumonia with autoimmune features is characterized as a provisional diagnosis for patients with ILD who have characteristics of autoimmune disease but do not meet the criteria for a specific autoimmune disease. This is a schematic representation of the spectrum of ILD with or without autoimmunity. CTD ILDs are characterized by clinical and biological features of autoimmunity and mostly treated using corticosteroids and immunosuppressive therapy targeting inflammation, whereas IPF is an idiopathic disease treated using antifibrotic drugs. IPAF lies within the spectrum represented within the spectrum between CTD related ILD and IPF in this oversymptomatic representation. This case highlights the complexity of diagnosing IPF, especially in the presence of coexisting infections such as tuberculosis. A high index of suspicion, thorough radiologic and serologic evaluation, and multidisciplinary collaboration are essential. Management should be individualized with immunosuppression guided by clinical course, and infection control should be prioritized. Thank you.
So this was a case of IPF with TB pleural effusion.
Yes, sir. Tubercular pleural effusion.
Okay. So let's say I'll give you a scenario in which there is TB pleural effusion and the CB9, the load is low, MTB load is low, and you have rift resistance detected. So what will you do in such a case? Rift resistance detected, MTB low in pleural fluid.
MTB detected low and MDR rift resistance is detected. So we will start on MDR regimen, and we will also send a repeat, but low detected. But so we will start on her antitubercular therapy.
Okay. So as per current guidelines, you are supposed to repeat at low and very low. Okay. These are the guidelines. Right. So you are supposed to repeat it.
Okay.
Do not start directly.
Okay. Also.
I just wanted to ask you, because this whole thing, do you feel it is an ILD or it's tuberculosis? Everything is tuberculosis?
No, sir. We mainly, because the CB9 report was positive for MTB, so yeah, we also treated her for tuberculosis, but we also started her on antifibrotics and low dose steroids for immunosuppression.
Now, my point is because because the CB9 is detected in the pleural fluid, right?
Yes, sir.
So the pleural fluid sensitivity for CB9 is just hardly 30 to 40%. That's all.
40%.
Around 40%. So most of the times you will not detect anything in pleural fluid, and majority of the times. Okay. Even it is a frank tubercular pleural effusion. So what have you done to the consolidations? What is there in the lung? So did you do a ball or anything like that?
No,
Nothing.
sir. Over time, in her second scan, moderate pleural effusion was detected. So we only did a diagnostic tag which detected CB9. CB9 detected MTB.
Now my own point is, so what is the primary diagnosis? Whether it is an ILD or it is only a tuberculosis which is presenting everything as ILD, consolidation, pleural effusion?
No, sir. She had complaints of breathlessness and dry coughs, which was chronic. So, and CT changes also showed changes of ILD.
So you have observed the patient for how many years?
So she was for a period of a month's time in our hospital and 1 month at a private hospital. So for 2 months, she was hospitalized on NIV support, not maintaining saturation, tachypneic. We gave her prone ventilation, and that is how she improved gradually.
So you totally followed for?
So we followed for ILD, but because CB9 detected MTB, we also started her on antitubercular.
Did you repeat the CT after?
Yes, sir. We did 2 scans.
After the completion of tuberculosis?
No, sir. She hasn't completed her course yet.
6 months now?
She has been on ATT for 3 months now.
So the CT was no, you have not repeated the CT
No,
again.
sir, but X-ray, radiologically, she showed improvement on AKT also, and she came for follow-up. Her X-ray is a lot better, and she's off O2 now, not on LTOT anymore.
Just two questions.
Yes, sir.
Is TB known to present as ILD? Number one, and number two, are false autoimmune markers possible due to TB as per the literature?
Sir, TB, sir, not sure.
That's the problem with IPAF, because to diagnose only on an ENA panel, extended nuclear antigen panel, you get some 1 plus JO, so 1 plus SSB. It is very, very difficult to label them as ILDs. So unless and until you have a consistent data or a CT scan or a history since long time, so you cannot definitely label them as an ILD, because most of the times all this, whatever you have shown on the CT scan, will disappear.
Okay.
So my own point is, if you want to label her as an ILD, after completion of ATT, please do a repeat CT.
Okay, sir.
So at least you will get to know if it is true ILD. So definitely it will stay there only,
Yes, sir, we will.
because
follow.
you are not given any steroid and all.
Sir, we did give her low-dose steroids over the course of 2 months.
After steroid completion in this.
Okay, so to differentiate. Yes, sir. Sure. Thank you. Yes, sir.
Let's say that this is the CTD, not IPAP. Can you enumerate some causes, like where you see effusions?
Okay. Rheumatoid arthritis is a CTD causing effusion, and other causes. So rheumatoid arthritis and only. So I know only one. Thank you.
Thank you. I now invite Dr. KVS Anil Prasad from RIMS Adilabad.
A case report of pulmonary zygomycosis. Zygomycosis is an opportunistic fungal infection, some forms of which may also be known as mucormycosis. Pulmonary mucormycosis is relatively uncommon but a life-threatening infection affecting most individuals with diabetes mellitus, hematological malignancies, chronic renal failure, post-transplantation and other immunocompromised states. We are reporting a case of chronic hemoptysis in a known case of diabetes mellitus. A 57 years old female known case of type 2 diabetes mellitus and hypothyroidism came with complaints of hemoptysis since 1.5 months associated with loss of appetite and weight. On general examination, patient was febrile, pulse rate of 86 beat per minute, blood pressure of 110/70 millimeter of mercury and respiratory rate of 16 cycles per minute. Examination of respiratory system revealed bilateral breath sounds equal, no added sounds. Her chest X-ray and CECT chest revealed cavitating lesion in superior segment of left lower lobe. A complete blood count showed hemoglobin of 10.3 gram per deciliter, total leukocyte count of 7,720 cells per cubic millimeter. Sputum examination did not reveal acid-fast bacilli, and sputum culture for pyogenic organisms was also sterile after 48 hours of incubation. Patient was being treated with antifibrinolytics, fresh frozen plasma, antibiotics and anti-diabetic agents, but her hemoptysis persisted. Patient had undergone bronchoscopy, during which whitish cheesy granulomatous tissue impacted at the apical segment of lower lobe was noted and biopsy was taken. Histopathology reports revealed it to be zygomycosis. At present, patient is being treated with liposomal amphotericin B infusion along with anti-diabetic, antifibrinolytic and cough suppressants. Coming to discussion, pulmonary zygomycosis is an uncommon opportunistic fungal infection. Diabetes have tendency to develop major airways lesion. This can lead to invasion of the airway wall and hilar vessels with infarction and severe hemoptysis. Management of pulmonary mucormycosis requires surgical intervention and correction of underlying predisposing factors. Medical therapy includes lipid formulation of amphotericin B and posaconazole as step down or as salvage therapy. Surgical intervention improves the overall prognosis. Surgical debridement in addition to the immediate first-line antifungal treatment is strongly recommended. Pulmonary zygomycosis is an emerging cause of infectious morbidity and mortality. However, there is no specific sign and symptoms, diagnostic criteria, and management of pulmonary zygomycosis. As the incidence of diabetes mellitus is rising both in developing and developed countries, it is important to make the general population aware about it and its complications. Aggressive management like lobectomy and controlling blood sugar level along with antifungals is a mainstay of the treatment.
So the radiological presentation was, what was the this radiological presentation of this?
Sir, cavitated lesion in the superior segment of left lobe.
Okay. So the message that you want to give is that in diabetics there should be good sugar control, and any cavity, it should have a differential diagnosis of this fungal infection also.
Yes,
What is the prevalence of this zygomycosis as per literature? Any literature? Any other risk factor other than diabetes for this?
Yes, sir,
As known in literature?
Like any chronic renal failures.
Okay.
The most common
Malignancy.
ones, like we check the oral cavity and everything for dental caries, alcoholics, chronic alcoholics, like who aspirate content. Okay.
Thank you. I now invite Dr. Shiva Sadala from RIMS Adilabad.
Right. Good morning, sir. Today I am presenting a case report of bronchoscopic guided treatment of subglottic stenosis using electrocautery and balloon dilatation. Introduction. Trachea and subglottic stenosis are chronic inflammatory process which can occur as a result of many etiologies, most commonly as a result of prolonged intubation and other causes such as chemical or thermal injury following direct trauma after bacterial or mycobacterial infections. Inflammatory diseases such as sarcoidosis and vaginal granulomatosis after radiotherapy, and finally idiopathic causes. After mucosal damage, inflammatory process will follow and it will activate the fibroblast, which leads to wound healing followed by scar formation and contraction at the stenosis site. Airway can be re-established by means of mechanical dilatation with bronchoscope, balloon dilatation, and laser ablation, or with combination of different methods. Case details: a 28-year-old male was brought with complaints of breathlessness, cough with minimal expectoration, and involuntary movements in 15 days. Patient gave history of previous hospital admission for poison consumption 2 months back, during which he was intubated and kept on mechanical ventilator support. Later tracheostomy was done and tracheostomy tube was kept for 10 days. He was also admitted on 24th of April and was diagnosed to have a hypoxic cerebellar syndrome. Bronchoscopy done was suggestive of subglottis stenosis, and bronchoscopy guided tracheal dilatation was done, which revealed stenosis at the level of fifth tracheal ring. Electrocautery was done followed by balloon dilatation. Post dilatation near completion, opening of the stenosis was achieved. Discussion. Benign tracheal stenosis secondary to prolonged intubation is one of the serious complications in the developing countries with incidence of 4.6%. The most well-known treatment modality for tracheal stenosis is open surgery, dissection of the stricture, and end-to-end anastomosis. Benign subglottic and tracheal stenosis can be safely and effectively managed with this interventional dilatation procedure using video-assisted flexible bronchoscope, cauterization, balloon dilatation, and mitomycin C after securing the airway with LMA for general anesthesia and optimal ventilation. Several balloon dilatations are beneficial for optimal outcome in patients with tracheal restenosis. Long-term results with minimal morbidity can be achieved with this surgical protocol. This is the X-ray taken, and this is the bronchoscopic images. In the beginning, in first image shows the stenosis, and last image that what we dilated. Conclusion: after securing the airway with LMA for general anesthesia, after securing the airway with LMA for general anesthesia and optimal ventilation, several balloon dilatations are beneficial for optimal outcome in patients with tracheal destenosis. Long-term results with minimal morbidity can be achieved with this surgical protocol. Thank you, sir.
Can you tell me some causes of tracheal stenosis other than intubation?
For like sarcoidosis and inflammatory diseases and infections like bacterial and some fungal infections and trauma.
So, will it be seen in active infections or as a secondary infections?
Sir, chronic infections.
Like
sir.
it can be seen in endobronchial tuberculosis.
Yes, sir.
Most common cause in India.
Yes, sir. Endobronchial tuberculosis.
It was a nicely managed case.
Sir.
It was a nicely managed case.
Sir.
It was nicely managed case.
Yes, sir.
Okay, sure. Thank you.
Thank you, sir.
Thank you. I please request all the presenters to stick to the time limit as we are running behind. I now request Dr. Shiva Sadala from RMS Adilabad. Sorry, Dr. Aditi Singh from IGGMC Nagpur.
Good morning. I'm presenting this paper titled Beyond the Breath, Leveraging Focus for Cardiac Insights in the Respiratory ICU, highlighting the role of focus in resource-limited government healthcare settings. Point of care ultrasound is an essential tool in the ER and ICUs. It provides instant bedside imaging, bypassing radiology delays, and identifies conditions such as cardiac tamponade, arterial thrombus, pulmonary edema, and massive pulmonary embolism. It also checks IVC status, significantly reducing time to treatment and improving patient outcomes. A 20-year male presented to the ER with complaints of breathlessness, cough, and chest pain for past 1 week. On examination, he had tachycardia, tachypnea, hypotension, and saturation of 84% on 15 liters NRBM. He had raised JVP, clubbing, stunted growth, and crepitations in the right infrascapular area. POCUS identified a C profile on right lung field, VSD, and right ventricular dilatation with hypertrophy on cardiac imaging. Later, elevated D-dimer and CTPA confirmed severe right ventricular outflow tract obstruction, overriding aorta, VSD, right-sided aortic arch, major aortopulmonary collateral arteries thrombosis with pulmonary infarction. Hence, based on POCUS and CTPA, the patient was diagnosed with tetralogy of Fallot with Eisenmenger syndrome with pulmonary infarction and MAPCA thrombosis. Patient was transferred to medicine ICU where he was started on anticoagulant therapy, beta blockers, and patient was counseled for heart-lung transplant. POCUS is a high-impact bedside imaging modality. It enables targeted evaluation. It has high sensitivity and specificity for common ED conditions. It speeds the triage and guides critical care. It cuts down CT and X-ray use, avoids patient transport, reduces ED stay length, and lowers healthcare cost. These are the images. Chest X-ray revealed scoliosis, cardiomegaly, and right lower zone cavitary lesion. ECG was suggestive of S1Q3T flattening. Cardiac focus images was suggestive of right ventricular hypertrophy, large non-obstructive subaortic VSD. Conclusion: POCUS is now needed to evaluate undiagnosed causes of breathlessness on site. As helpful in this case, Focus is a vital bedside tool in the ICU settings and ER. It enables rapid diagnosis of complex cardiopulmonary condition, expedites treatment, and improves patient outcomes by reducing reliance on delayed imaging.
So you have mentioned that we can monitor cases and diagnose the cases of pulmonary edema as well, right?
Yes.
And pulmonary arterial hypertension. How do you measure it? Through focus?
ब्लू प्रोटोकॉल रहता है उसमें वी चेक द प्रोफाइल्स there's A profile, A dash profile, B profile, C profile, and we check IVC status also. But according to that we.
Okay.
Can you tell the typical clinical features of TOF?
So there is a overriding of aorta.
Clinical features.
Clinical features. So cyanosis and dyspnea, and it presents early during the childhood, and text spells रहते हैं sir, cyanotic spells रहते हैं.
So can you describe a typical cyanotic spell in childhood? How it presents?
So due to any exhaustion, crying episodes, or taking a patient comes in a tripod position and then
Squatting episodes.
Squatting episodes.
Thank you. I now request Dr. Akansha Ratan from IGGMC Nagpur.
Good morning, everyone. I'm going to do a case report, lost and found ectopic thyroid masquerading as a mediastinal mystery. Ectopic thyroid is a rare clinical entity which is a result of abnormal embryogenesis of the thyroid gland. It can be present anywhere from in the course of the obliterated thyroglossus duct. It constitutes less than 1% of all mediastinal tumors, mediastinum being the rarest site for the presentation of an ectopic thyroid. My case was a 64-year-old female, and she had history of chest heaviness and exertional breathlessness for 20 years with a non-contributory general examination. We did a chest X-ray which showed a large, well-circumscribed homogeneous opacity. We were suspecting a thymoma or a teratoma initially, so we went for serum alpha fetoprotein and a serum CEA. The alpha fetoprotein was normal and serum CEA was mildly raised. We went for a thyroid profile which was also normal. On CT, we found out a well-defined heterogeneously enhancing mass in the superior mediastinum with multiple coarse calcific foci and non-enhancing areas. The patient was referred to surgery, and she underwent thoracotomy with excision, and the histopathology confirmed a mediastinal colloid goiter. This is an intra-op picture of the mass showing a large mediastinal mass that was excised from the mediastinum, and the histopath shows colloid-filled thyroid follicles which are lined by the flattened cuboid epithelium. Ectopic thyroid tissue is a rare developmental anomaly. While investigating a mediastinal mass, we should keep in mind that lymphomas, germ cell tumors, substernal thyroid, neurogenic tumors could be the possible differentials. However, ectopic thyroid should not be missed given its rare presentation. Radiological imaging like CT and MRI can be used to determine the extent of the mass, and we can go for a CT guided FNAC and also an EBUS transbronchial needle aspiration for the diagnosis. It is more commonly presents in females with a ratio of 4:1, and it is a result of the aberrant embryogenesis of the thyroid gland during embryogenesis. The surgical resection is the treatment of choice because it can lead to complications like it can cause compression of the vital mediastinal structures. It can undergo malignancy in 15% of cases, and these are the complications. The conclusion is our case, an elderly female symptomatic with a large mediastinal mass, on evaluation turned out to be ectopic colloid goiter. without connection to the original gland in the neck, and it is a very rare presentation. However, it must still be considered as one of the differentials. With the possibility of complications, further investigation and surgical excision is necessary and useful for both diagnosis and the treatment.
So, what are the most common types of mediastinal tumors?
The most common types of mediastinal tumors could be thymoma, it could be a teratoma or germ cell tumors, it could be a thoracic aorta, it could be a terrible lymphoma, and it could be a thyroid.
Okay. So, how will the PFT be in this patient?
Sir, we did a PFT in this patient and it was suggestive of small airway obstruction and nothing else.
Small airway.
Yes, the patient can have obstructive symptoms, can have obstruction due to the mediastinal mass. So the PFT will be suggestive of obstructive pathology.
What will be the shape of PFT curve?
The shape of PFT curve in spirometry, it will be the extrathoracic part will be
Box type.
flattened.
In box type,
Box
okay?
type.
Extrathoracic or
Box type is fixed obstruction.
Okay. So, which one do you see in this patient?
It is an intrathoracic obstruction, so the expiratory part will be flattened.
Okay.
Thank you. I now request our next speaker, Dr. Neha Jain from IGGMC Nagpur.
Today's title is Tuberculosis Associated Hypercoagulability Presenting as Acute Limb Ischemia. Introduction. Tuberculosis in past decade has emerged to be a risk factor for development of venous thromboembolism. However, its association with arterial thrombosis is very rare, 0.01%. This case highlights TB-associated hypercoagulability as a rare but severe cause of acute arterial thrombosis. A 30-year-old male chronic alcoholic presented with sudden onset pain, numbness and calf tenderness in right leg with loss of appetite and loss of weight. Patient was already on ATT at the time of admission with sputum AFP smear 4 plus positivity. Patient gives past history of PTB in January 2024, for which he took ATT for 4 months, followed by further loss to follow up. There was no history of trauma or cardiovascular disease elicited or other drug intake. Chest X-ray was suggestive of bilateral infiltration. On admission, patient was vitally stable with bilateral crepitations or auscultation. His right lower limb was cold, tender to touch, with peripheral pulsations present. We did an D-dimer test to rule out pulmonary thromboembolism. It was raised. PTINR was deranged. ECG and echo were normal with PA suggestive of normocytic normochromic anemia. Doppler ultrasound and CT angiography of lower limbs revealed extensive arterial thrombosis from right common iliac artery to distal tibial vessels. He underwent successful mechanical thrombectomy with sequential balloon angioplasty with stenting and was managed on dual antiplatelets and cilostazol, pentoxifylline, hydrostatins. Chronic alcohol use, malnutrition, and a background of active TB likely contributed synergistically to the thrombotic event. The causal mechanism beneath this association is yet to be elucidated. Arterial occlusion in TB patients demand high clinical suspicion and prompt vascular intervention. Chest X-ray was suggestive of bilateral infiltration with right upper lobe fibrosis. This is pre-procedure CT lower limb angiography, post-procedure CT lower limb angiography. Conclusion, TB with its varied many presentations can be baffling. When venous thromboembolism in tuberculosis has been a topic of interest in past few years. However, a couple of case reports showing the disease association with arterial thrombosis have also come to light. Early identification and prompt management leads to better salvage of affected limbs.
In this case, what do you feel the cause of arterial thrombus? Is it alcoholism or tuberculosis?
It can be both, sir, because patient was already on ATT. Previously, we had not. It can be both, sir. It was acting synergistically, we thought, because there was no other cause. There was no history of drug intake or any trauma to the leg.
Yeah, probably more of alcoholism because it is more documented than tuberculosis. See, chronic alcoholism itself is a hypercoagulable state because of all liver damage and increased inflammation and all. So probably TB can be an associated feature in this, but probable cause of hypercoagulation is alcoholism in this case, most probably.
What was the hemoglobin in this patient?
Hemoglobin's at 10. 10 grams per day.
Okay. Patient was non-smoker, non-alcoholic in this case?
Alcoholic, sir. Chronic
Alcoholic. Non-smoker. Okay. Fine.
Thank you. Our next speaker is Dr. Sharad from LN Medical College, Bhopal.
Good morning, everyone. Today I am presenting paper on effect of duration of smoking among young adult male on spirometry and functional exercise parameters of lung health. Introduction is tobacco smoking and its impact on lung health. Tobacco smoking is a leading preventable cause of early lung function decline, major risk factor for COPD, lung cancer, pulmonary hypertension, heart failure, recurrent respiratory infection. Cumulating smoking exposure per year directly worsen lung damage. Even asymptomatic young smoker can have early functional impairment. Importance of early functional assessment. Early spirometric and exercise limitation often precede clinical symptoms. Pulmonary function test, FVC, FEV1, FEV1 by FVC ratio to detect early airway obstruction. 6-minute walk test, simple practical tool to assess functional capacity of normal adult male. Case detail method to assess the effect of smoking duration of spirometry in 6-minute walk performance. Objective to evaluate lung function via spirometry to assess functional exercise capacity. 6-minute walk tests. Correlate smoking exposure categories with spirometry and 6-minute walk test performance. Material method study design cross-sectional observational studies. Sample size 120 young adult male smoker. Category into ABC. A less than 4 pack a year, B 4 to 8 pack a year, or group C more than 8 pack a year. Parameter is spirometry and 6-minute walk test. Result: spirometry progressive decline in FVC, FEV1 and FEV1 FVC ratio, increasing smoking exposure. FEV1 FVC ratio decrease from group A to C, significant difference between group A versus B and group A versus C, but no significant difference between group B and group C. 6-minute walk test, progressive reduction in 6-minute walk distance with increased smoking exposure. Group A 450 meter, group B 380 meter, group C 320 meter. Discussion: dose dependent decline observed. The study demonstrates a significant progressive decline in spirometry parameter, FVC, FEV1, FEV1 by FVC ratio, and 6-minute walk test distance with increasing smoking exposure among young adult male smoker. Early functional impairment detectable, notable, while spirometric value plateau at higher smoking exposure. Importance of early screening. This highlights the value of incorporating routine spirometric 6-minute walk test assessment in young adult asymptomatic smoker, especially in high-risk population, to identify early lung impairment and initial preventive strategy like smoking cessation. Spirometry parameter across smoking group and 6-minute walk test distance across smoking group. Conclusion: prolonged smoking in young adult male leads to early asymptomatic decline in lung function and exercise capacity. There is a clear dose-dependent relationship between smoking exposure, airflow limitation, and reduced physical performance. Spirometric decline tends to plateau at higher exposure, but functional limitation 6-minute walk test continues to worsen. Early screening with spirometric 6-minute walk test is essential for timely detection of subclinical lung impairment. Structural smoking cessation programs should be prioritized for this high-risk young population. Thank you.
Can you just tell the 3 groups A, B, and C?
Yes, sir.
What were they? How was the patient selection criteria?
Pack year according to pack year. If pack year is less than 4, then group A. Pack year 4 to more than 4 to 8, group B, and more than 8 is group C.
Pack years.
Yes, sir.
So these are young adults, right?
Yes, sir.
So how did you recruit them for your study?
In OPD basis, sir.
Why did they come to you for smoking? They came to you.
No, sir.
So were they patients or were they from some general population?
General population, sir.
Office staff, something like this?
My own point is
MBBS
because
student.
you are saying it's a healthy adult.
Yes, sir.
And you're saying the smoking is only the factor.
Yes, sir.
But once the patient comes to the OPD with something else, He's not going to become a healthy adult, right? You would have had
No,
some.
sir. Students, MBBS student, PG student, and
Acha,
staff.
it's a
Students.
Yes, sir.
randomized study, basically.
Focus.
Yes, sir.
So for how many years you have done this?
1 year, sir.
Over 1 year, so you have seen the decline in lung function.
No, sir. Over 1 year study, sir.
No, like you must have followed up with the patient, right?
Yes.
What was the decline in lung function? Was there a decline in lung function?
In group C version, sir.
How much was the decline?
How much? Sir,
It's not so common, right? See, probably 20-year-olds.
sir, but even spirometry is good, but 6-minute walk test, they cannot perform more than 400 meter in group C. Group B.
So more than group C is how much? More than how many packets?
More than 8 pack year.
You don't see so quite often, right? Because 20-year-old, you don't see.
Sir, even spirometry can give good result, but it's in 6-minute walk test, they cannot perform 400 meter.
All right.
Do you think the addition of a control group of non-smokers would have helped us tell that this is more smoking related?
Yes, sir.
Okay. ठीक है ना? Thank you.
Thank you, sir.
Thank you. I now invite Dr. Ashok Choksi from LM Medical College, Bhopal.
Morning. The topic is microbiological profile and clinical impact of my study was on microbiological profile and clinical impact of bronchoalveolar lavage and non-responding pneumonia. That is an observational study in central India. Introduction. Community acquired pneumonia remains a major global health concern, causing significant morbidity and mortality. A subset of patients failed to improve within 72 hours of empirical antibiotic therapy termed non-responding pneumonia. In central India, challenges are amplified by high burden of tuberculosis, rising antimicrobial resistance, presence of atypical and opportunistic infections. Empirical therapy often fails due to poor sputum sample quality, prior antibiotic usage, undetected atypical pathogens, bronchoscopy with valve enhances the pathogen detection, especially for smear negative TB and gram negative infection. This study evaluated the microbiological profile of non-responding pneumonia and assess the role of valve in improving diagnosis and outcomes. Study was of 1 year, and aim was to explore and the study to utility of bronchoscopy and valve as the diagnostic tool in managing patients with typical pneumonia not responding to the antibiotic therapy. So objective was identify the causative bacteria pathogens etiology in non-responding pneumonia, evaluate the diagnosis and therapeutic role of bronchoscopy with valve, assess the clinical improvement and outcome following valve. Study design up for over 12-month period and including criteria over the age group of 12 years. Clinical and radiological feature of typical pneumonia, no prior TB or malignancy, and consent for bronchoscopy. Exclusion criteria sputum positive TB, diagnosed lung malignancy, recent MI, and fit for bronchoscopy. Procedure: all underwent bronchoscopy with valve under local anesthesia. Valve tested gram stain, AFB, QH mount, bacterial, fungal culture, CB0 for tuberculosis, cytology for malignancy. Statistical analysis was performed using microscopic Excel and species version 26. Descriptive statistical work applied to demographic and clinical data, while patients paired student t-test compared pre and post intervention respiratory rate and antibiotic duration and p-value less than 0.05 considered statistically significant. Results: demographic majority were middle age group with male predominancy. Male age group was 47.1 years, gender 50 were male and 30 were female. Microbiological finding: there was Pseudomonas predominancy, Arizona 21 cases, Mycobacterium tuberculosis 19 cases, clavicle Klebsiella pneumonia 6 cases, and no pathogen detected 30 cases. and there is significant reduction in clinical symptoms and antibiotic durations. Discussion. Pseudomonas aeruginosa and Mycobacterium tuberculosis were the predominant pathogens in non-responding pneumonia cases in central India. Ball achieved 59% diagnostic yield, outperforming non-invasive method and reaffirming the value of fibrotic bronchoscopy with Ball. 41.25% cases remain undiagnosed, indicating possible atypical viral or non-infectious etiology such as pulmonary embolism or drug-induced pneumonitis. CB0 and Ball enable early detection of tuberculosis in sputum negative patient in TB endemic regions. So these are the numbers out of which 21 so Pseudomonas aeruginosa, and that is a significant 26.25%, Mycobacterium tuberculosis 19, that percentage is 23.75%, and Klebsiella 6, no pathogen 30. It is also more a number, and that's significant symptom reduction cough, expectorant dyspnea and pneumonia. Conclusion. Fibrotic bronchoscopy involves significantly enhance the microbiological diagnosis of non-responding pneumonia, particularly valuable in TB endemic regions like central India for early detection of gram-negative infection, and enable timely targeted therapy adjustment contributing to faster clinical improvement. Based on these findings, early use of VAL is justified in appropriate selected patient with non-responding pneumonia.
So the top two organisms were Pseudomonas and TB.
Yes.
In your study. Okay. So do you recommend BAL in all sputum negative cases of TB?
TB gram which was not detected, it was excluded.
Okay. Exclusion criteria. Could you just repeat the exclusion criteria of your study?
Typical pictures of pneumonia was included.
Okay.
And sputum negative like tuberculosis.
Okay.
Is included in this study.
Okay. Can you define two terms for me? One is slowly resolving consolidation and one is non-resolving consolidation.
Non-resolving, there is no symptomatically benefit improvement after 2 weeks, and in radiological improvement in 4 weeks.
Okay.
And in non-responding, there is given some after giving injectable antibiotic if it is not responding within 72 hours.
Okay.
What is BOO?
BOO.
Are you aware of any procedure called mini BAL?
Yes, sir.
What is it?
Sir, it is usually used in ICU setup when a patient ventilator. So by ET tube, by 20 to 22 sizes of suction tube. In mucus extractor, we suction the lavage. So it is.
In some patients, you found TB, means in second, TB was the second highest, right?
Yes, sir.
So in these patients, was induced sputum done or not?
And even atypical cases is more than.
No. Induced sputum, was it done or not in these patients? Induced sputum.
After induced sputum.
Okay. Yes. So prior to bronchoscopy, you did induced sputum in this patient?
All criteria was excluded. Tuberculosis. After there is no sputum production despite after giving some mucolytic therapy.
Okay.
Thank you.
Thank you. I now invite our next presenter, Dr. Ayush Butera from IGGMC Nagpur. Please stick to your time limits, please.
A very good morning to all of you. The topic is open negative syndrome in tuberculosis, a rare diagnostic dilemma post-treatment. Introduction. Open negative syndrome ONS is a rare but clinically important manifestation in the spectrum of treated pulmonary tuberculosis. The syndrome represents a paradox between radiological and microbiological findings. Patients with open negative syndrome are generally non-infectious, although the radiological appearance may suggest the active disease. Open negative syndrome is especially relevant in high TB burden regions like India, where overlapping presentations may result in misdiagnosis, prolonged or unnecessary treatment, and inappropriate isolation measures. Case details on A 23-year-old female patient presented with the chief complaints of fever, cough, anorexia, and weight loss for 2 months. Her vitals, heart rate 102 per minute, BP was 160 by 60 per minute, saturation was 97 on room air, and respirator 24 per minute. Chest X-ray revealed a cavitatory lesion with an air fluid level. Sputum examination was done. AFB smear showed 1 positive, and CVNAT was MTB detected. Patient underwent antitubercular therapy for 1 year. And after 1 year, on follow-up, patient showed significant clinical improvement along with weight gain and resolution of symptoms. On follow-up, sputum smear was done, which was negative for AFB, and CBNAT was also confirmed that MTB was not detected. However, the chest X-ray continued to show a cavitatory lesion without any signs of active infection, infiltrations, or any air fluid level, which was confirmed later on HRCT thorax and leading to the diagnosis of open negative syndrome. Monthly sputum smears were negative for AFB up to 6 months after the completion of the treatment. So the diagnostic criteria for open negative syndrome included here was initial active pulmonary tuberculosis, that is documented cavitatory pulmonary tuberculosis with positive sputum smear or NAT prior to the initiation of therapy, and microbiological conversion, that is sputum smear or NAT convert to negative during the treatment and remain so for at least 6 months. Persistent non-infectious cavity imaging, that is X-ray or CT, showing a persistent thin-walled cavitatory lesion after more than 12 months of treatment without any clinical or radiological signs of active infection. These are the pre-treatment and post-treatment images of the patient. Chest X-ray showing cavitatory lesion with the air fluid level, and which is also seen in the CT scan, which are resolved after, in the post-treatment. We can see the cavity lining of the cavity without any air fluid level, which can also be seen on the CT scan. So the conclusion is open negative syndrome poses a significant diagnostic challenge in tuberculosis management. Its incidence is approximately 9%. The clinical awareness is essential, particularly in high burden TB regions, to prevent misdiagnosis and unnecessary initiation of anti-TB therapy. Accurate recognition of open negative syndrome, a careful multidisciplinary approach is essential to prevent overtreatment and guide proper follow-up and distinguish it from the relapse or drug-resistant TB. Thank you.
How long do you follow up the patient? For
this patient, we had given antitubercular therapy for 1 year, and after that, every monthly we had done sputum smear for 6 months.
For 6 months?
Yes.
Okay, so it was negative throughout the 6 months.
Yes.
So like misdiagnosis is very common, as you said, in these patients. Whenever the patient goes to a physician, especially.
Yes, sir.
So they always come to a conclusion that it's tuberculosis.
Sir, anyone who is not aware with this can be restarting the treatment, looking at the cavitatory lesion, even if the patient has minimal symptoms or suggestive of infective symptoms.
So how regularly do you follow up with such patients?
Sir,
bi-monthly or 6 monthly?
For first 6 months, a monthly sputum AFB smear should be done, and after that 6 monthly follow-up. So,
if the patient doesn't have any symptoms?
Sir, that is one of the criteria for labeling it as open negative syndrome.
Oh.
Under the program, what is the post-treatment follow-up schedule? After that, let's say today the patient has completed treatment.
Yes.
So for how long and how frequently would you like to follow up the patient under program recommendations?
Sir, 6 monthly, then after 1 year.
After treatment, till what duration the patient should be under follow-up?
2 years.
So it is 6 monthly till 2 years.
Yes. Thank you.
Thank you. I now invite our next presenter, Dr. Divya Wankhede from IGGMC Nagpur.
Good morning to all. Today I am presenting an oral paper on decoding the etiology of opaque hemithorax, a case series on diagnostic insight and challenges. Introduction. The opaque hemithorax represents a diagnostic challenge with diverse underlying causes. This case series highlights the key radiological patterns, clinical correlation, and diagnostic strategies to unravel its etiology and improve the patient care. Methodology. Identify the patient with unilateral opaque hemithorax on chest X-ray. Apply the inclusion criteria, which include complete imaging and the clinical data. Next, we have the advanced imaging like CT and sonography, identifying underlying causes, and then diagnostic correlation with clinical and lab histopathology. The final diagnosis was made, etiological classification was done, and the case has been documented. So now we'll see the result. First is the mediastinal shift away from the opaque hemithorax. Case 1, 31-year-old young female with CT suggestive of underlying mass, with biopsy suggestive of malignant small round blue cell tumor and IHC suggestive of Ewing sarcoma. The diagnosis was Ewing sarcoma. Next, we have a 39-year-old male with chronic alcoholic CCT suggestive of pancreatico-pleural fistula, cola-colored fluid hair with raised amylase and lipase. The diagnosis was pancreatic pleural effusion. Third case, 31-year-old male with constitutional symptoms with positive pleural fluid CBNAT. The diagnosis was tubercular pleural effusion. Next result, we have mediastinal shift towards the opaque hemithorax. The first case was 52-year-old male, post-operative, post-extubation with sudden onset of breathlessness. Bronchoscopy was done, mucus plug present, no culture on the bowel. Diagnosis, left lung collapse. Second case, we have the 65-year-old female with post-lung cancer surgery, surgical marks present over thorax, diagnosis, left pneumonectomy. Third case, 58-year-old male with history of PTB, CT suggestive of left-sided pleuroparenchymal fibrosis with pull of trachea to the same site, diagnosis, left fibrothorax. Next, first part is going off no mediastinal shift. Young male came with a fever, cough, dyspnea with history of traveling, chest X-ray suggestive of CT suggestive of consolidation with air bronchogram, bronchoscopy, mucopurulent secretion present with bowel culture growth present, diagnosis left-sided massive consolidation. Then we have the mimics of opaque hemithorax, which include kyphoscoliotic changes and also include the fibrothorax. Conclusion. Diagnosis of an opaque hemithorax require correlating imaging pattern such as mediastinal shifts with clinical context to uncover the underlying cause and guide the effective care. Thank you.
Right. Can you tell me a cause of effusion without any mediastinal shift? A massive effusion.
So there can be a fixed mediastinum. So like endobronchial growth can be present along with the massive effusion. So that generally happens in the malignant effusion with the malignancy present in the mediastinum.
Okay. Any other pleural causes?
There can be some loculated pleural effusion as well with a multiple thick and thin septa. That is also not pushing the mediastinum to the opposite side. So that's why there is a no shift in the mediastinum in that cases.
Any malignancies?
Some mesothelioma.
Can you tell the clinical features of diffuse pleural thickening?
Diffuse pleural thickening.
Clinical findings, what you'll get in diffuse pleural thickening?
So in diffuse pleural thickening, patient can present with a dry cough or progressive dyspnea can be present, sir. Along with that, exertional breathlessness is present.
On examination?
On examination, sir, fine crepes present on auscultation.
Okay. And can you tell some cause, any etiology of diffuse pleural thickening you are aware?
So fibrotic, it can be post-TB changes as well, sir.
Non-infective?
So poisonous, like there is poison. So
Anything related to asbestos?
chronic asbestos exposure can lead to that.
Okay.
Thank you, sir.
Thank you. I now invite our next presenter, Dr. Chidambaram from IGGMC Nagpur.
Good morning, everyone. My topic, bleeding lungs and broken valve, a rare case of alveolar hemorrhage unmasking severe aortic stenosis in young alcoholic male. Introduction, diffuse alveolar hemorrhage is a rare condition with reported mortality ranging between 20 to 100%. There are many etiologies of diffuse alveolar hemorrhage. Cardiac disease are likely underreported causes of diffuse alveolar hemorrhage. Heart failure and mitral valve disease are most common cause of cardiac cause of diffuse alveolar hemorrhage. The DAH results from pulmonary venous hypertension leading to stress failure of pulmonary capillaries. There is also a contribution of bronchial circulation. The alveocapillary membrane or blood gas barrier is extremely thin structure that allows rapid and passive diffusion of oxygen from inhaled air to pulmonary capillaries while preventing pulmonary edema and DAH with chronic elevation of transmural hydrostatic pressure. Case details. A 30-year-old male chronic alcoholic pawn shop worker presented with worsening breathlessness for 10 years, acute onset of cough with expectoration, frank hemoptysis 4 to 5 episodes per day with bilateral dull chest pain for 5 days. On examination, he was tachypneic, tachycardia and fall of oxygen saturation. Chest X-ray shows bilateral diffuse alveolar infiltrates and ECG suggestive of left ventricular hypertrophy. Initial suspension of viral pneumonia led to empirical treatment with antibiotic and antivirals, but CBC reveals sequential fall in hemoglobin. USG thorax shows here CBC hemoglobin reports. USG thorax shows altered echo structure of liver with the bilateral pleural effusion. However, the condition remains same. The sputum sputum suggestive of Staphylococcus aureus and patient CB0 and viral panels negative. Antibro BNP shows 458 picogram per ml. On further investigation, CECT thorax suggestive of patchy area of consolidation with interstitial septal thickening and adjacent ground glass opacities in bilateral lung parenchyma with bilateral pleural effusion and mild cardiomegaly. 2D echo shows severe aortic stenosis, severe eccentric aortic regurgitation with global hypokinesia, ejection fraction less than 30%, mild pulmonary hypertension and aortic wall thickening with calcification. The patient was diagnosed as a very severe aortic stenosis, aortic regurgitation with heart failure with reduced ejection fraction and diffuse alveolar hemorrhage, possibly complicated by infective endocarditis. Treatment include IV methylprednisolone pulse therapy, diuretics and supportive care and antibiotics therapy. The patient condition improved, then we referred the patient for CVTS for definitive surgical management. These are all the serial chest X-rays and CT. This is post valve replacement chest X-ray. Conclusion: this is a rare presentation. Diffuse alveolar hemorrhage as a manifestation of severe valvular heart disease, highlighting the need for early cardiac evaluation in young patient presenting with unexplained hemoptysis and pulmonary infiltrates, especially in background of alcohol use.
What is the role of anti-pro-BNP?
Sir, anti-pro-BNP, if raised means we can suspect pulmonary edema.
In this case, like you have suspected some cardiac cause, right?
Sir, patient patient having breathlessness and we on USG patient having bilateral pleural effusion also. Initially we suspected cardiac failure also, so we done anti-pro-BNP.
Basically, you're saying we can differentiate between pulmonary and non-pulmonary causes, cardiac causes.
But very unusual, right? Because you said severe aortic stenosis, global hypokinesia, EF 30%, less than 30%. Pro-BNP of 450 doesn't sync well. Usually it should be 4,000. It doesn't sync well with the echo findings. Maybe it is done after the treatment or what?
So on during not in anti-pro-BNP we done during the treatment course, not initially. On suspicion, we later we done.
Yeah, that's the reason. Because that's the reason it's not correlating, right? Because you have so much of global hypokinesia, EF less than 30%, you will not see anti-pro-BNP of 450. It will be more than 2,000, 3,000 most of the times.
Thank you.
Thank you. I request our next presenter, Dr. Lajwanti Lalwani, who is a senior faculty at Savangi Meghe.
Good morning. I will be presenting assessing the relationship between dyspnea and hospital anxiety depression scale score in respiratory patients admitted in tertiary care center. Coming to the introduction, dyspnea, the subjective experience of breathing discomfort, is a common symptom in respiratory disease. Though it is a physical consequences, dyspnea is also strongly related to psychological symptoms, particularly anxiety and depression. HADS is a valid instrument designed to assess the anxiety and depressions. The untreated psychological condition negatively affect adherence, rehabilitation, and quality of life. So there is a need to include the psychological assessment of dyspnea. There is a limited data on the finding of relationship between HADS with dyspnea. So the study aims to evaluate the association between dyspnea severity and HADS score in patient admitted in tertiary care. Coming to the methodology, this was an observational study carried out in a department of pulmonary medicine. It was a 6-month, 144 patients were included as per inclusive and exclusive criteria. Inclusion criteria was informed consent and diagnosed with respiratory disease and were able to answer the questionnaire. Exclusion criteria were ultrasensorium. Methodology, patients were screened as per criteria and they were evaluated for dyspnea using MMRC scale and anxiety and depression using HADS. These are the result. Graph 1 pie diagram shows the gender-wide distributions where 90 were male patients and 54 were female. The mean age was 52 plus minus 14 years. Graph 2 shows diagnostic distribution of the patients. Now coming to the figure 1, which is a scatter diagram, which shows a correlation between MMRC grade and HADS score. A significant positive correlation was found between MMRC grade and both anxiety and depression score. And we have also came across a regression equation because it has not passed the normality. So Spearman was then an R value for anxiety was 0.61 and for depression was 0.54. Coming to the discussion, the present study was conducted to evaluate the association between dyspnea and HADS in patients admitted to tertiary care respiratory unit. And the result showed there was a moderate positive correlation of MMRC with anxiety and depression. The results were supported by studies done in 2006, which concluded that there is a causal relationship between development of symptoms of anxiety and depression and dyspnea. The psychological status is therefore important factor to consider while treating patients with dyspnea. Similarly, a study was done in 2017 on COPD patient where they concluded that anxiety and depression are common symptoms in COPD and there is a positive correlation between them. In 2020, also a study was conducted which shows there is an association with depression, anxiety and coexisting anxiety depression. And the probable reason can be anxiety. Because of anxiety, patient try to hyperventilate and because of that also there is increased dyspnea. Conclusion, the study concluded there is a moderate positive correlation between dyspnea severity as measured by MMRC score and elevated levels of anxiety and depression. The regression equations are this. There was limitation, we have not taken into consideration BMI clinical status. Further scope, further studies on treating the psychological aspect for effective supplementary treatment in relieving dyspnea as such as palliative care, rehabilitation, relaxation should be taken into consideration. Thank you.
Did you come across any patient with psychogenic hyperventilation in your study?
No, sir.
No.
But
So-
that it is generally seen.
So how can we identify patients with psychogenic hyperventilation?
They will just maybe they will not be associated clinically with any pathology, but they will be anxiety attacks which may present as hyperventilation.
So can we distinguish patients with coexistent anxiety and patient with psychogenic hyperventilation?
I'm not sure about it.
Okay. Is there, we have not included quality of life. So if we would have included quality of life also, just a comment that it would have shown us the impact that both these factors, the anxiety as well as
Quality of life.
the dyspnea, they have on quality of life.
Yes.
Because that is the ultimately the parameter of clinical importance to the patient. Thank
Will
you.
include. Sir.
Any help from psychiatrists in this?
No.
Like antipsychotics that we can add. Generally, we come across a lot of patients in OPD.
I have actually excluded patients who had on psychiatric treatment with respiratory diseases.
Okay. Fine.
Thank you.
Thank you. Thank you to our judges and presenters. We will have the award distribution at 1 p.m.